I'm Sheila Martins, President-elect of World Stroke Organization. I would like to welcome to everyone. It's a pleasure to be here for more one activity of the Brain and Heart Week promoted by World Stroke Organization Brain and Heart Task Force together with World Stroke Academy. We have here with us wonderful panelists, but before we start, I'm very pleased to announce the launch today of the first ever World Stroke Organization Stroke Support Organization Mapping Report. The report includes data from 92 organizations from 58 countries. It gives insights into their profile and how they are contributing to improving stroke outcomes. I know from my own experience that SSO, stroke support organizations, are key collaborators for clinicians and researchers. Please find the report on the WSO website under what we do. Thank you. Now, let's start with the lectures from these amazing speakers, starting with Simona Sacco from Italy, talking about is migraine without an embolic TIA. Simona, please.
Hello, I wish to thank the organizers for inviting me to give this speech as about cardioembolism as a cause of migraine with aura. There's my disclosures and there is nothing relevant to this talk. What I will show you over the course of the presentation is that cardioembolism may induce some attacks of migraine aura, and that cardioembolism may, at least in part, mediate the increased vascular risk associated with migraine. On the other hand, migraine is a complex condition and cardioembolism is only one among many possible migraine triggers, and so it is plausible that migraine cannot be cured by suppressing cardioembolism. Migraine is a common and complex disease arising from an interplay between genetic factors which provide the substrate of the disease and endogenous and exogenous factors which may contribute to migraine occurrence in the predisposed brain. There is a number of conditions which have been associated with migraine, and patent foramen ovale is one among them. Additionally, we have solid evidence from the literature that a subtype of migraine, which is migraine with aura, is associated with a twofold increase in the risk of vascular diseases and in particular in the risk of ischemic stroke. Migraine aura consists in focal neurological symptoms progressing over minutes, which usually occur before headache. The neurophysiological substrate of the aura is considered to be cortical spreading depression, CSD, which is a slowly propagating wave of rapid, near complete depolarization of brain cells that suppresses brain electrical activity for several minutes. CSD can activate downstream trigeminal vascular nociceptive pathways and can cause head pain in migraine, but also in secondary headaches. In fact, CSD is not specific of the migraine aura, but may occur in other conditions and diseases. There is a good experimental evidence showing that in the mouse model, the injection of microemboli in the carotid artery may trigger cortical spreading depression. CSD occurrence depends on the duration and the degree of occlusion, as well as on the size and the composition of the embolic material. Air microinjection in the mouse was the most reliable CSD trigger. Usually microemboli trigger also hypoperfusion together with the CSD, often without infarction. However, in this experimental study, around 30% of mice had microinfarction. Large particles caused more lesions, and this observation is also of potential important for stroke in humans. There is also evidence in humans that embolism may induce bioelectrical phenomenon in the migraine brain. This is a study on a limited sample of patients with migraine, with aura, and with and without PFO, and in subject with PFO but without migraine. Cerebral air embolism provoked by microbubble injection induced EEG power changes only in migraine with aura patients with PFO, but did not induce the same bioelectrical modifications in patients with PFO without migraine and in migraine patients without PFO. The same phenomenon described after the injection of embolic particles in the carotid territory can be observed with the thrombotic occlusion of a single penetrating artery. Therefore, microembolism of a single small artery can trigger migraine attacks in humans, as well as be responsible of vascular lesions. But what is different in the migraine brain is that it seems to be more vulnerable to the negative effects of spreading depression than the non-migraine brain. In fact, in this experimental study of induced stroke, CSD-related changes were more severe in the migraine model compared to wild type. The migraine model showed accelerated lesion growth and larger infarct. Therefore, cerebral hypoperfusion may remain unnoticed in the non-migraineur brain, but may cause neurophysiological alterations and, in some circumstances, also vascular lesion in the migraine susceptible brain. The microvascular lesions we commonly observe in migraineurs may represent the consequences of those mechanisms. In fact, we know that migraineurs, as compared to those who do not have migraine, have more commonly white matter abnormalities, infarct-like lesions, and volumetric changes in gray and white matter. Also, human studies support increased tissue vulnerability in migraine. Studies with the brain MRI indicate that in the setting of acute ischemic stroke, the migraine brain exhibits a smaller amount of penumbral tissue and consequently a more rapid expansion of brain infarction, thus supporting the increased tissue vulnerability that was shown in the experimental model. We know since many years that there is an association between the presence of PFO and migraine, in particular with the migraine with aura. And we know that also that some observational studies showed that PFO closure may lead to improvement in migraine. This led to perform some randomized controlled studies. However, those RCTs did not show overall benefit of PFO closure as a strategy to prevent migraine attacks. However, subgroup analysis, such as the analysis of the PRIMA trial, showed that there may be some benefit of PFO closure in migraine with aura, thus further supporting that some auras may represent the consequence of microembolism through the PFO. I want also say that by knowing the migraine pathophysiology, we cannot expect to cure the disease by PFO closure, because in this way we will suppress only one of the numerous possible triggers of migraine, and we do not eliminate the migraine substrate. This is a further clinical study which may support the link between cardioembolism and migraine aura. It is from the ARIC cohort. The authors evaluated the association between migraine with aura and incident atrial fibrillation, as well as whether atrial fibrillation mediates the risk of ischemic stroke in patients with migraine with aura. Authors found an independent association between migraine with aura and the risk of incident atrial fibrillation compared to patients without headache, and also relative to individuals with migraine without aura. Mediation analysis showed that atrial fibrillation was a mediator of migraine with aura-related ischemic stroke risk, and as such, some migraine with aura could be regarded as a specific type of TIA related to cardiac microembolism. The same evidence is supported from findings from the Oxford Vascular cohort. Here, authors showed that in stroke patients there was an association between migraine and cryptogenic stroke. And we know that cryptogenic stroke is associated with patent foramen ovale and occult atrial fibrillation. We cannot think to cure migraine by suppressing cardiac embolism, as this is only one of the possible migraine triggers. On the other hand, we have to consider that in the experimental migraine model of middle cerebral artery occlusion, migraine prophylactic drugs that suppress CSD susceptibility reduce in an effective way the number of ischemia-triggered CSD. And those drugs can also improve or even normalize the severe stroke phenotype. And those findings support that it is better to target the migraine substrate than trying to suppress the embolism. So in conclusion, my take-home messages are that cardioembolic conditions, and in particular atrial fibrillation and PFO, have been associated with migraine and with migraine and stroke. Microembolism in migraine may account for some of the auras, and they also bear the potential to lead to symptomatic and asymptomatic brain lesions. And brief ischemia may have a higher likelihood to cause tissue injury in migraineurs as compared to those who do not have migraine. But microembolism is not the exclusive mechanism in migraine, and selected targeting of microembolism, for example, by closure of PFO, cannot represent a cure for migraine. There's still a lot to do in this field, because if we want to target the vascular risk associated with migraine, we have to develop strategies to identify migraineurs at particular risk of ischemic stroke, and we have to understand if we can modify the vascular risk and how we can do this. It's also very important to understand the possible long-term implications of the microembolism in the brain and of the increased tissue vulnerability of ischemia, and particularly in terms of chronic brain conditions and long-term risk of cognitive decline. At least we have not to forget that migraine has been associated with the risk of vascular diseases other than stroke, for example, myocardial infarction, and with a systemic vascular dysfunction. And it's very important to understand how we can put this in the overall context. Thank you for your attention.
Great, Simona, thank you. The questions will be answered at the end. You can put in the question and answers. So now let's talk a little bit more about the brain-heart connections with young Scheitz from Germany. He will talk about Takotsubo syndrome secondary to stroke. Jan, thank you.
Thank you, Sheila, for the kind introduction. I'm happy to join the webinar Stroke in the Brain-Heart Axis and to talk about Takotsubo syndrome in acute stroke. I have no specific conflicts of interest apart from the fact that I'm fascinated by the brain and heart axis. I would like to start my presentation with the clinical case of a 72-year-old female patient that we treated the end of November last year at our department, and that you may also encounter in your everyday clinical practice. So she had a mild left MCA stroke, and in accordance with the American Heart and American Stroke Association guidelines, we measure cardiac troponin levels upon hospital admission in order to estimate the cardiac status of the patient and to identify patients with myocardial injury. And upon hospital admission, this was pretty normal, below the upper reference limit. And in accordance with the local SOP, we repeat troponin measurement within the first 24 hours on the stroke unit. And here we observed a marked increase, 25 times increase of cardiac troponin levels. So we had evidence of an acute myocardial injury. Her ECG showed atrial fibrillation without tachycardia and no specific T-wave inversions. The patient had no obvious signs of cardiac problems, cardiac symptoms, but remember that she was not able to communicate because of her aphasia. So altogether we had unexplained myocardial injury, which was acute. So therefore we ordered an echocardiogram, which showed an acute heart failure with a markedly reduced ejection fraction and also an apical hypokinesia of wall motion abnormalities. And later, after a discussion with our cardiologists, we decided to perform coronary angiography, which ruled out acute coronary syndrome. So we found no evidence of obstructive coronary heart disease. But on the levocardiogram, we still found reduced ejection fraction and then also an apical ballooning at the end of the systole, meaning that the apical parts of the heart were not contracting regularly. And we repeated the echocardiogram later on day 10 after hospital admission, and there was recovery of the wall motion abnormalities and recovery of cardiac function. So this altogether is a typical constellation, typical setting to diagnose Takotsubo syndrome. So the unexplained myocardial injury in this case was obviously Takotsubo syndrome secondary to stroke. So what is Takotsubo syndrome? What is Takotsubo syndrome? There are several synonyms used in the literature. For instance, broken heart syndrome, stress cardiomyopathy, apical ballooning syndrome, and in the setting of stroke and subarachnoid hemorrhage, you often read neurogenic stunned myocardium. So basically, Takotsubo syndrome is an acute heart failure syndrome which can mimic acute coronary heart disease, and it is assumed that 3 to 5% of patients with suspected acute coronary syndrome have indeed Takotsubo syndrome, especially when it comes to elderly female patients. Typically, as mentioned in our case, we have recovery of the ventricular function within a couple of weeks or month. The name Takotsubo syndrome originates from Japan, where the syndrome was first described, and the authors of the first description found that the levocardiogram, the apical ballooning pattern observed in the end of systole, resembles a Japanese octopus trap, a clay jug which is used to catch octopus, and this is called Takotsubo. You can see it here in the middle of the slide. And so obviously Takotsubo syndrome is a rather novel disease entity, and you can see here the PubMed records with papers about Takotsubo syndrome, and you can see that within the last 10 to 15 years, we have a lot of literature about Takotsubo syndrome. Here you can see the age and sex distribution of patients affected by Takotsubo syndrome. And as you can see, females, lighter blue bars, are more than 10 times more often affected than men. And females aged older than 55 have a 5-fold increased risk of Takotsubo syndrome compared to younger females. And this slide is just to point out that there are more types than the classical apical ballooning type, which I presented in the case and which was first described in Japan. As you can see here on the left side, the apical ballooning type. There are also midventricular, basal, and focal types, which make up to 20% of patients. And there is some evidence that these variants may be more common after neurological disease. And this is relevant because these atypical patterns of Takotsubo syndrome are sometimes more difficult to diagnose. So how can we diagnose a Takotsubo syndrome? There are several established diagnostic criteria. So first we need to document a ventricular dysfunction with wall motion abnormalities that extend a single coronary vessel. And then typically we have ECG alterations, and we also have clearly elevation of cardiac biomarkers like cardiac troponin and especially brain natriuretic peptides. And as you can see here in the middle part, highlighted with the red box, neurological disorders may serve as triggers for Takotsubo syndrome. So what do we know about triggers of Takotsubo syndrome? Classically, Takotsubo syndrome was described after intense emotional triggers such as anger and grief, and this is why you often read broken heart syndrome in the media. But nowadays, we know that Takotsubo syndrome is also very common after physical triggers like critical illnesses and neurological disorders such as stroke seem to be the most common physical triggers that have been described. So we have 1/3 of patients with emotional stress triggering Takotsubo syndrome, 1/3 physical stress, with neurological disorders being the most relevant group of disorders here. And we have 1/3 of patients without an identifiable trigger. And with regard to the pathophysiology, we know that catecholamines and especially norepinephrine levels are markedly increased after Takotsubo syndrome and are markedly higher than what can be observed in patients with myocardial infarction, for instance. You can see it here. The red bars represent patients with Takotsubo syndrome, and we have an increase of norepinephrine levels shortly after the symptom onset, which is prolonged over a couple of days and still higher than norepinephrine levels observed in patients with myocardial infarction, as you can see in the blue bars. Now, what I really found interesting is this study from a group from Göttingen, Germany, who used a model of inducible pluripotent stem cells. And the group found that an increased beating frequency of cardiomyocytes from Takotsubo patients compared to cardiomyocytes from control patients. And the beating frequency was higher after incubation of catecholamines. So there seems to be an increased sensitivity for catecholamines on a cellular level in cardiomyocytes of Takotsubo syndrome patients. And colleagues from Zurich, Switzerland, have also shown that this altered stress response probably originates in the brain, and there might be an individual susceptibility in the brain to develop Takotsubo syndrome. Using brain MRI studies, the colleagues found a reduced cortical volume in both insular cortices, and they also found a reduced volume of the amygdala, which are both important regions in the brain that constitute the central autonomic network and that promote the physical response to emotional stress. And the colleagues also found that there seems to be a functional problem in the central autonomic network, and they found a hypoconnectivity in sympathetic and parasympathetic networks in Takotsubo syndrome patients compared with matched healthy controls. And so what do we know about the prognosis of Takotsubo syndrome? For a long time, Takotsubo syndrome was considered a benign disorder because of the recovery of ventricular function, which I mentioned, and because when it was compared to patients with acute coronary syndrome, the common perception was that Takotsubo syndrome is rather benign, but we know from large registries such as the INTERTAC registry that there's a considerable morbidity and mortality in patients with Takotsubo syndrome, and mortality can be as high as 20% after 5 years. And when we then compare mortality to patients with coronary heart disease, we can see a similar mortality. You can see here the red curve represents patients with Takotsubo syndrome, and the green curve represents matched patients with coronary heart disease. And you can see a similar mortality here, which is higher than matched patients without coronary heart disease, the blue line. And here you can see the most common early complications that we should all be aware of when we treat patients with stroke and patients on the neuro-intensive care unit. So very commonly we have heart failure, which we should treat respectively, and sometimes cardiogenic shock. But we should also be aware that some patients develop rhythm disorders, and especially atrial fibrillation. And sometimes there's also left ventricular thrombus. So this means that patients with Takotsubo syndrome are also at risk to develop embolic stroke. And this is what the guidelines recommend regarding the treatment of Takotsubo syndrome. So very briefly, we should use and offer prolonged cardiac telemetry, and we should consider treatment with ACE inhibitors and beta blockers, especially in those patients with signs of heart failure. We should definitely avoid use of inotropes such as norepinephrine, and we should also avoid QTc prolonging drugs in order to avoid the development of arrhythmia. And finally, we should consider prophylaxis of thrombosis and embolism in these patients. So what do we know then about Takotsubo syndrome after stroke? So first we know from several registries, and here I show you the largest registry, the INTERTAG registry, led by Christian Templin and his group in Zurich, Switzerland. We know that there's a really high prevalence of acute neurological disorders that may trigger Takotsubo syndrome. And we know from a national US inpatient sample and a publication from the group from New York that stroke and especially subarachnoid hemorrhage are the most relevant neurological diagnosis with the strongest association with the development of Takotsubo syndrome. And in this sample, the diagnosis of Takotsubo syndrome after neurological disorders was rather low. However, it increased markedly with a higher awareness of the syndrome in the last years. What do we know about Takotsubo syndrome and ischemic stroke? Case series have shown that Takotsubo syndrome may occur in approximately 0.4 to 1.2% of patients, but this can be markedly higher if we select a group of patients with elevation in cardiac biomarkers such as cardiac troponin. So there was one case series of consecutive patients with echocardiography from Japan, which showed 1.2% of patients with Takotsubo syndrome, all female patients, all elderly patients in this cohort, and most patients had moderate to severe stroke. And in this case series, all patients had the typical apical ballooning variant. And then in a larger group, also a larger cohort, also from East Asia, we had a lower frequency, 0.4% of patients with consecutive patients with echoes conducted. And in this cohort, there was a lower proportion of females than expected in general Takotsubo groups. And we saw that the stroke severity was rather high. Median NHSS was 16 in this group. And the majority had a typical Takotsubo syndrome pattern. And the colleagues performed a matched analysis in order to answer the question whether patients with Takotsubo syndrome after ischemic stroke have a poor prognosis. And they found an approximately threefold higher risk of in-hospital mortality and a higher rate of early clinical deterioration. And I would like to highlight one very interesting finding from the series, which was that when it comes to lesion site of the stroke, the colleagues observed a higher frequency of right hemispheric lesions, and also they observed a higher frequency of insular lesions. And this is really interesting because the insular cortex, as I mentioned earlier, is part of the central autonomic network. And we have observed previously that lesions in the right anterior insular cortex are associated with stroke-associated myocardial injury. So damage in this particular region may promote the occurrence of cardiac complications such as myocardial injury and also Takotsubo syndrome. When it comes to subarachnoid hemorrhage, we know that the prevalence of Takotsubo syndrome during the first few days after the hemorrhage is approximately 10 times higher than what we see in ischemic stroke, ranges from 10 to 20%. And there seems to be a higher relative proportion of males that can have Takotsubo syndrome after subarachnoid hemorrhage. So the proportion seems to be higher than 15%. And there seems to be also a higher proportion of atypical variants. This is why you often read neurogenic stunt myocardium in the setting of subarachnoid hemorrhage, which rather describe the atypical variants, the midventricular and basal involvement of the wall motion abnormalities. There also seems to be an association between a higher clinical severity, higher Hunt and Hess rate in patients that develop Takotsubo syndrome after subarachnoid hemorrhage. And this also seems to be an increased rate of in-hospital mortality. So if we now take a step back and offer a more general perspective, Takotsubo syndrome can be considered as a part of a spectrum of cardiac complications that can be observed after stroke, and which we have summarized as a so-called stroke heart syndrome. And we know that all the spectrum of cardiac complications share the same risk factors, such as premorbid heart disease and older age, and also share the same stroke-specific determinants, such as lesions in the central autonomic network and higher clinical severity. And we also know that patients affected by the whole spectrum of cardiac complications after stroke have higher rate of poor short-term and probably also long-term outcomes. From taking together, it is very likely that the brain-heart axis is strongly involved in the pathogenesis of Takotsubo syndrome. And we know that from intense emotions, they can overactivate the central autonomic network, leading to an excess release of neurohumoral mediators, such as catecholamines, and that this can lead to Takotsubo syndrome. And as I showed you, there's evidence that a similar chain of events take place after acute stroke, like we have damage and dysfunction in the central autonomic network, leading to Takotsubo syndrome. And inflammation after stroke probably also plays an important role. And you will hear more about the pathomechanisms in the talk from Luciano later, in which he will cover the topic of stroke-induced heart injury, SIHI. So I would like to summarize my talk, and I hope it became clear that Takotsubo syndrome is a unique example of a neurocardiogenic syndrome, and that if we know more about Takotsubo syndrome, we will learn more about how the brain and heart interact. I told you that Takotsubo syndrome occurs in approximately 1% of patients after ischemic stroke and 10 to 15% after intracerebral hemorrhage, and especially subarachnoid hemorrhage. However, there are only very few systematic and well-controlled studies, and I strongly believe that Takotsubo syndrome and also the variants, the atypical forms, are likely underdiagnosed, and we should be aware of the syndrome, giving the relevant morbidity and mortality that are associated with Takotsubo syndrome. I also told you that lesions in the central autonomic network, especially the insular cortex, may promote the development of Takotsubo syndrome. And finally, so if we have unexplained elevation of cardiac biomarkers, such in the case I presented at the very beginning of my talk, and if we have ECG alterations, especially altered repolarization, if we have unexplained cardiac symptoms, we should consider Takotsubo syndrome as a potential differential diagnosis and should perform echocardiography in a timely manner and get involved both cardiologists and neurologists in order to find out whether Takotsubo syndrome is going on or whether other diagnoses such as acute coronary syndrome take place. So thank you for your attention, and I hope that you enjoy this webinar, and I'm open to for further questions. Thank you very much.
Wonderful, Jan. Great talk. We have several questions, but will be at the end. So now I'd like to introduce Dr. Luciano Sposato. He has a large experience to talk about stroke-induced heart injury, a novel pathophysiological concept to be targeted with innovative therapies. Luciano is leading the Brain and Heart Taskforce. Thank you, Luciano.
Hello, I'm Dr. Luciano Sposato. I'm head of the stroke program at Western University. I'm chair of the WSO Brain and Heart Task Force. I would like to thank you for attending this presentation and this webinar. And I'm going to start sharing my, my slides immediately. So the topic of my talk is stroke-induced heart injury, a novel pathophysiological concept. And I will try to walk you through how cardiovascular complications happen after stroke. These are my disclosures. And we estimate that around 1 million deaths occur annually around the world just because of cardiovascular complications after stroke. But this is just the tip of the iceberg. There are many other cardiovascular complications that have been identified after stroke onset. Perhaps one of the most common ones is ischemic and non-ischemic myocardial injury, which usually expresses as elevations of cardiac troponin. And it's important here to note that the elevation has to follow the rise and fall pattern, meaning that it increases soon after stroke and then it decreases and goes back to its baseline levels. Acute coronary syndromes are frequent also. They can present as acute MIs or non-MI acute coronary syndromes as well. Left ventricular dysfunction is one of the common presentations of cardiovascular complications after stroke. One of them is just asymptomatic left ventricular dysfunction noted on echocardiographic studies. Patients may still develop symptomatic left ventricular heart failure or insufficiency. And as Dr. Scheitz very nicely presented, some patients, although not so common, can present with Takotsubo syndrome after stroke. Electrical abnormalities are also common. We have very common findings of abnormal ST or T wave changes, which happen in almost all types of strokes. And there's a specific type of arrhythmia that may have a neurogenic pattern, and it's called atrial fibrillation detected after stroke, or AFDAS. When we put all together these cardiovascular complications and cardiovascular death, we have the stroke heart syndrome, which was also very well described in the paper by Dr. Scheitz and collaborators in Lancet Neurology in 2018, and was more recently updated in our paper in JAG last year. So to put this in numbers, at 1 year after stroke, about 9.1% of patients without any prior heart disease and with a first ever ischemic stroke do present with cardiovascular complications. And those complications, even in these patients who do not have any evident history of heart disease, are more frequent than ischemic stroke or TIAs, and are more frequent than intracranial hemorrhage. At 3 years, this number is even larger, with almost 16% of patients presenting with new onset or incident cardiovascular complications. So looking at this in more detail, in the study that I was showing you in the previous slide, we defined MACE as, or major adverse cardiovascular events, as the presence of myocardial infarction, incident CAD, new PCI or CABG, incident heart failure, or cardiovascular death. We did not include incident AF. And we did find that both MACE as a primary endpoint and secondary endpoints such as myocardial infarction, incident CAD, or cardiovascular death were significantly more frequent among patients with first ever ischemic stroke compared to patients who never had ischemic stroke, who were propensity matched, and where and then these results were adjusted for some other variables in Cox regression analysis. Perhaps the most interesting part is that many of these patients did develop CHF or heart failure, which is something that is quite surprising, I would say. We have almost 6% of patients who developed heart failure during follow-up compared to less than 3% in the overall population matched by age, sex, and risk factors. So of course we found more AFib, but this is probably related to more thorough screening for AFib after stroke. The other interesting aspect is that most of the risk of cardiovascular complications after stroke, or the stroke heart syndrome, is time varying. So it means that within the first 30 days, there's a 25-fold higher risk of cardiovascular complications after stroke, even if we do our best to prevent them by using any kind of secondary stroke prevention strategies. The risk remains independently high at 90 days, with a 5-fold increase compared to patients without stroke. And it remains, it still remains high at 1 and 3 years, with a 2-fold higher risk in stroke patients compared to those without previous stroke. And what I would like to highlight here is that that cardiovascular complications still happen after stroke, even if we have improved diagnosis and treatment for patients with stroke, and even if they adhere to healthier lifestyles such as vegetables, fruits, more exercising. And as I showed you before, even if we do all this, patients still have cardiovascular complications at a rate or a crude rate of 9.1% per year. So the take-home message here is that we need to target mechanisms. We need to target the pathophysiology of cardiovascular complications after stroke, and that's what we call SIHI, or stroke-induced heart injury. So what is SIHI? SIHI has 3 main levels of action. The first one is the cerebral level. That's where the strokes happen and where we find the inflammation and autonomic dysregulation. The second one is the systemic component, which involves inflammation and autonomic dysfunction, as I'll show you in a few minutes. And the third one is the damage that occurs locally at the myocardial level. So let's focus on the cerebral changes. Soon after a patient has a stroke, there is neuronal death, and the microglia become activated. That results in cell debris and phagocytosis, which ends up activating the inflammasome caspase-1 complex, which is responsible for transforming interleukin-1 beta into the active form of pro-interleukin-1 beta into interleukin-1 beta, which we will see that has a very important, and I would say central role in the pathophysiology of SIHI, or stroke-induced heart injury. This same interleukin-1 beta further stimulates more activated microglia, and this generates persistent and quite damaging inflammation. So we looked at this in a rat model in which we injected endothelin-1 into the right and left insular cortex, and we then looked at the heart and brain pathology at 28 days. And we did find some interesting results here, which we have not published. The first paper is published, but we haven't published this yet. And it shows that after the injection of endothelin-1 into the right insular cortex at 28 days, as you can see here, there is a lot of M1 microglia, which is responsible for tissue damage, as you can see in green here, which is also accompanied by a quite substantial activation of M2 microglia, which are the cells that are in charge of tissue recovery. So there's a fight here between tissue damage and tissue recovery, which is most intense at 28 days after stroke, which means that there's persistent inflammation, and there are things happening here that may have consequences more remotely at the level of the brainstem or the spinal cord or autonomic nerves. So what happens at the systemic level? And these are also some interesting things which, again, have a central role for interleukin-1 beta. Interleukin stimulates the adrenal gland, and that results in the systemic release of epinephrine and norepinephrine. At the same time, it stimulates interleukin-1 receptors at the cerebral level, as we clearly know more recently, and that results in a functional impairment of the autonomic transmission system, which further stimulates adrenaline receptors at the adrenal gland level, and that enhances the catecholamine response. At the meantime, or at the same time, interleukin-1 receptors are activated within the spleen and bone marrow, which results in the activation of monocytes into macrophages and more activation of neutrophils, which are released to the systemic circulation, resulting in systemic inflammation. This is further stimulated by the splenic nerve at the level of the spleen, where noradrenaline stimulates alpha receptors and enhances this inflammatory response. And this is probably related to damage to the central autonomic network at the level of the brain or brainstem. Again, the norepinephrine further enhances the inflammatory response by acting over beta receptors on inflammatory cells and enhancing or further releasing interleukin-1 beta. So as you see here, there's a massive inflammatory response after stroke that affects both the systemic inflammatory markers and the local autonomic system at the level of the brain and spinal cord. So we measured this in rats with endothelin-1 strokes and those who were injected with saline, and we found a peak at 6 hours and then another peak at 28 days, which correlates with the amount of inflammation occurring at the level of the brain. So these are possible targets for preventing inflammatory consequences at the level of the myocardium if we can inhibit the interleukin-1 receptors. So what happens at the level of the myocardium? Again, the same model, the rat with injection of endothelin-1 on one group, injection of saline in the insular cortex on the other group. And what we're seeing here is panleukocytes, neutrophils, T lymphocytes or B lymphocytes. And we see that there is a massive inflammatory response at 28 days in the left atrium of rats who received strokes in the right insular cortex and left insular cortex compared to those who did not receive strokes because they were just injected with saline. Similar findings here. We looked at the micro coronary circulation, and we found, as you can see here, signs of endothelial dysfunction in those vessels, which can explain why patients have troponin elevation and why some other patients have myocardial infarctions without any evidence of plaque or atherosclerosis of the major coronary arteries. And finally, this is quite a striking finding of fibrosis. Everything that you see in blue here with the Mason trichromatic staining is fibrosis in the left atrium, which is much prominent in rats with left and right insular cortex strokes compared to those who were injected with saline. So this could be the substrate for cardiac arrhythmias, given the fibrosis that impairs the conduction system. And Another interesting finding in our model is that there was correlation between the degree of left atrial fibrosis and the severity of microglia activation in several regions of the brain that were not directly involved by the stroke itself. So it means that even remote inflammation in the brain can lead to, or can or at least correlates with fibrosis in the left atrium. But this is not the only thing that happens to the brain. There are lots of other things happening that are related to the release of catecholamines and the action of interleukin-1 beta. As you can see here, the release of catecholamines and the interleukin-1 beta stimulates fibroblasts that evolve to myofibroblasts, and that results in fibrosis, as I showed you before. The direct action of catecholamines results in a contraction band necrosis and subendocardial hemorrhage, which can also be the substrate for cardiac arrhythmias, given that the conduction system goes through or is in relation with the subendocardial tissue. The catecholamines themselves can also impair contractility, resulting in left ventricular dysfunction, and can increase oxygen demand, which in the context of the endothelial dysfunction that I showed you before, maybe plaque rupture and more in the long-term atherogenesis, can favor apoptosis and ischemic necrosis, subsequently leading to left ventricular dysfunction after patients experience a myocardial infarction. And as you can see here, the catecholamines and interleukin-1 beta seem to stimulate the myocardial fibers, which release nerve growth factor, resulting in sprouting of the sympathetic nerves and increasing the catecholamine response in a kind of circular way, which results in chronic catecholamine and inflammation-related damage. So to summarize, SIHI is the consequence of acute and chronic inflammation and the release of catecholamines at the level of the, acting at the level of the myocardium. So these are two possible targets for preventing cardiovascular complications after stroke. One of them is interleukin-1, the other one is probably noradrenaline. So there are two different strategies that could be tested for these patients. One of them is the use of interleukin-1 antagonists, and the other one would be the use of beta blockers targeting the receptors that are stimulated by the adrenaline and noradrenaline. With this, I'm finishing my talk, and I would like to thank you for your attention, and we are now open for questions. Thank you very much.
Wonderful, Luciano, thank you. Several questions here. So congratulations to all for amazing talks. Let's start with Simona. Simona, what about migraine without aura and risk of ischemic stroke? Is there a link?
Thank you. This is really a great and important question. Well, migraine with without aura are not definitely two separate conditions, because it happens often that a patient has some aura attacks, then the aura attacks stop, and then they start again later in life. So I think it's worth not to consider them really two separate conditions. Having said that, the literature data indicate that anyhow also subjects with migraine without aura have an increased risk of ischemic stroke. However, here the evidence is less clear, probably because the amount of the risk is smaller.
Okay. Another about migraine. Are there any connections between stroke in patients with migraine in sex, a specific type of aura, and use of contraceptives?
Okay, another very, very good question. Referring to sex, the association has been proved both in men and in women. But in women, we have many more data, and the data is more robust because about 70-80% of those with migraine are women. The second part of the question referred to the type of aura. Here I have to say that the visual aura is the most common one in clinical practice, and most of the data refer to patients with visual aura because this was most reliable to be recognized by the questionnaire which were used in the study. So the data we have mostly refer to visual aura, but I do not see any reason why it should be different for sensory or for dysphasic aura. And the third part of the question referred to the use of hormonal contraceptive. This is a very, very important thing because it happens very sometimes in clinical practice that we see young women who have migraine and who have a stroke after starting hormonal contraceptive. And we have data from the literature, and we have several studies which showed that combined hormonal contraceptives, that are contraceptives which contain both estrogens and progestogens, are associated with an increased risk of ischemic stroke. This was proved years ago when hormonal contraceptive had higher levels of estrogens, but has been confirmed even by more recent study in which women employed a lower dose of estrogens, such as 30 micrograms of ethinyl estradiol. So finally, yes, the answer is yes, there's an increased risk of stroke in women with migraine with aura with the combined hormonal contraceptive, and so there are guidelines which recommend against the use of combined hormonal contraceptive in women with migraine with aura. If I can say some few more words, I want to say that, however, there's a difference according to the indication for the use of the hormonal contraceptive, because if this is used only for contraception, we can consider alternative strategies such as non-hormonal contraceptives or the progestogens only contraceptive. It's a bit different if women use the combined hormonal contraceptive for therapeutic reasons, such as, for example, for endometriosis or for polycystic ovary syndrome. Here, the trade-offs between risk and benefit is different, and if the woman really needs the combined hormonal contraceptive for therapeutic reasons, it's allowed, it's possible to use it because there are no alternatives.
Perfect. One more about migraine to three of you. First for you, Simona. Do you consider secondary prevention of stroke in patients with migraine and MRI with microvascular changes? So prevention in patients with migraine and MRI with microvascular changes. First you, and after Luciano, and after John.
Another great question. This is a common issue in daily clinical practice, especially for those who run general neurology or the headache center, because it's really, really common. Unfortunately, we do not have any evidence which shows if patients can have benefits by applying a specific preventive measure. So far, there's no indication to start, I want to say, an antiplatelet or something else. But on the other hand, we would like to do something for our patients, especially when we see them, then we see again them after a while, and there's an increase in the number of vascular lesions. Even when we see the increase of the vascular lesion, we do not have nothing to say that we have to start some specific treatment. What can be suggested is to screen for the factors which may further contribute to the occurrence of those lesions, because they can be related only to the presence of migraine, but we have to check if there can be other factors which are recognized and may contribute to the occurrence of those lesions. So a thorough check to the common vascular risk factor, and also check to some unconventional mechanisms which may play a role in some patients.
Perfect. Luciano, in your routine, what will you do with these patients?
I think Simona addressed this very, very nicely. There's no evidence for using aspirin, but what I think is that it depends on where you're seeing the patient. If it's someone who came to the TIA clinic with a differential diagnosis between TIA or migraine, and you then look at the MRI and you see that there are lots of white matter lesions, and it's a person who may have other risk factors, I would probably use aspirin, because there is a component of increased platelet aggregability in patients with migraine, and that could be one of the stroke mechanisms. But it's totally empirical, right? No evidence, and it might be a wrong thing to do.
Perfect. Jan, and you?
Yeah, thank you. I absolutely agree to what has been said. So we won't do this regularly for primary prevention settings, and we would also check thoroughly for comorbid cardiovascular risk factors contributing to the lesions, such as hypertension and so on, and tackle these risk factors accordingly, I think.
Perfect. Now, about Takotsubo syndrome for you, Jan. Takotsubo is more common with the right insular insult. Any specific reason for that?
Yeah, I tried to explain this during my talk, that the insular cortex is an important region in the central autonomic network, which is involved in the autonomic response from like emotional stress to the heart, and mediates like a rise in heartbeat and blood pressure rise. So if we have a stroke located in the insular cortex, this central autonomic network is more disturbed than when the stroke occurs in a different region. And this is why we have this particular autonomic activation probably here. And this may be one reason why we observe Takotsubo so often in the insular cortex region. Perfect.
About this, you talked that stress can be the trigger for the Takotsubo syndrome. Some study showing that anxiolytic therapy can decrease the incidence of a Takotsubo syndrome with emotional stress.
This is a really interesting question. So in addition to neurological disorders, there's also evidence that psychiatric disorders and anxiety and depression also are risk factors for the development of Takotsubo syndrome. But I'm not aware of a specific study trying to treat with analytics. And what is interesting is that if you have Takotsubo secondary to an emotional stress, it doesn't mean that you get it with the same stress in the second time. So recurrence of Takotsubo is rather rare. So for just to prevent Takotsubo, I would not take anxiolytics.
Okay, thank you. Luciano, you know something about it? Some study with anxiolytics that can decrease the Takotsubo syndrome?
No, I'm not aware of any studies. No, well,
Okay.
very good.
Okay, for Jan again, how many time does it take after a stroke until Takotsubo syndrome will install? Immediately or after hours or after days? What's the most common?
Yeah, so usually we observe this within the first few days after ischemic stroke. And if we remember what Luciano Sposato just presented in his talk, the mechanisms regarding stroke-induced heart injury. So they have an immediate component, which will immediate autonomic surges and immediate pro-inflammatory events taking place. And then we also have some parts that need some more time to develop. So from my clinical perspective, we observe this in the first few days, and after subarachnoid hemorrhage, even earlier sometimes, because here we have a more intense and paroxysmal brain damage and stimulation, and more global brain damage and stimulation.
Perfect. Thank you. We have thousands of questions about troponin. We will talk a little bit about it after, but first for Luciano. Since many of these brain-heart interactions appear to be catecholamine mediated, any studies to see if plasma catecholamine levels can be a biomarker to identify these patients that will go ahead to develop cardiac sequelae following acute stroke? Or
Yeah, that's an excellent question. And there is a correlation between catecholamine levels and stroke severity and then myocardial injury. So it could be used in theoretical in clinical practice, but there are no clinical studies showing that it's beneficial to measure catecholamines to improve outcomes, because that has never been done. But there is a clear relationship between the severity of the stroke and catecholamine levels.
perfect. For you, Luciano, again, are individuals with post-stroke seizures at an increased risk of heart injury dysregulation compared to those with no seizures after stroke? Do you think seizure can increase the heart damage?
Well, we have SUDEP, right, as one of the consequences of seizures in patients with epilepsy in general, and that's supposed to be due to dysregulation of the autonomic system. And we know that when people with surgery for seizures get the insular cortex stimulated on the right or the left side, we get different responses in terms of heart rate or even the release of catecholamines. So there's a clear relationship between seizures, dysautonomic dysregulation, and then even cardiovascular death or cardiac death, definitely.
Perfect. Thank you. Now about troponin. For you, John, you see several stroke patients with elevated troponin and apical wall motion abnormalities after stroke, often indicating heparin drip for treatment of non-STEAM complication. Often the size of stroke precludes early anticoagulation in these patients. The knowledge that non-STEAM like situation could be arising just from this stroke, it's okay to non-anticoagulate these patients? Did you understand the question? Patients with a stroke and also with apical wall motion abnormalities that should be anticoagulated. Do you think you cannot anticoagulate because the size of a stroke, if the motion alterations can be caused by stroke?
Yeah, I think this is an excellent clinical question and a difficult problem in our everyday clinical practice. I mean, it's similar when we have a patient with ventricular thrombus because of other reasons, or because if we have left atrial appendage thrombus and so on. So in general, Takotsubo syndrome can lead to the development of ventricular thrombus, and from a general perspective, we would recommend to do prophylactic heparin treatment, and if we detect a thrombus, then start anticoagulation. But yeah, it depends, of course, on the stroke lesion size. But if there truly is thrombus, and you should check with echocardiograms in these patients, then yeah, your individual weighing of risk and benefits probably favors early anticoagulation then.
Okay. One more about troponin after we'll talk a little bit about migraine. How high can be the troponin after stroke? Because sometimes it's very difficult to manage this patient in acute stroke.
Yeah, this is also an excellent question. So we've seen everything from sky high troponin levels to just minor troponin elevations. And in general speaking, you can say that the higher, the more likely there is acute coronary syndrome, the most relevant differential diagnosis. But this is only a very yeah, inaccurate rule of thumb. So you need to thoroughly examine patients with echocardiography, talk and ECG, of course, and talk to the cardiologists and make an interdisciplinary decision. So yeah.
It's very difficult. I remember when we start to request troponin when in acute stroke, the cardiologist always would want to go to the cath lab with the patient. So we have to learn more about this because it's a challenge in the acute phase. How can we differentiate Takotsubo cardiopathy and a current myocardial infarction? You need to do serial troponins, echocardiography, and so how often until when we serious troponin?
Yeah, so this is exactly what you've just alluded to. I think it's not easy to differentiate Takotsubo syndrome from myocardial infarction in the individual patient, and you really need yeah, a closer look to all the other things like ECG, like yeah, serial troponin measurements, the degree of change in serial measurements. So all of these things are important, and yeah, sometimes the wall motion pattern in the echocardiography can help to distinguish. So I would recommend to perform, if possible, serial echocardiograms during the first few days and see how where it goes. And if you decide with your cardiologist, there may be some patients that finally go to the cath lab, and we've shown that also coronary angiography is quite safe if we conduct this for in a diagnostic fashion after the first few days after stroke. So difficult, and I make just highlight that a lot of these questions are answered in our JACC paper, which was the paper of the month selected by the WSO. So there's also a kind of algorithm how to interpret troponin elevation, so you can read it there.
Perfect. Thank you, Jan. Luciano, do you want to answer the question about topiramate? Topiramate for prevention of stroke in migrainous patients?
Yeah, so I don't have any. So the question is, how about topiramate for preventing stroke in patients with migraines? I'm not aware of any evidence about the use of any prophylactic medication in clinical trials. Simona showed some data, but I don't know if Simona, you want to comment on that.
Yes, the data was in the experimental animal, and they showed that topiramate can reduce the cerebral hyperexcitability associated with migraine and reduce the size of the infarction. However, there are, as Luciano said, we do not have data in humans, and we know very well that what was evident and clear in the experimental animal, in many cases, unfortunately, was not confirmed in human studies. So far, we cannot use topiramate for this indication.
Sheila, can I ask you a question to
Yes. Yeah.
I hear a lot the word troponinitis. What do you mean? Or not what do you mean, but what do you think about that?
Yeah, so sometimes when we implement, some years ago when we implemented troponin measurements, there's always a discussion with the cardiologists and other colleagues. Why do you measure this? It's always elevated. And there's a German saying that if you don't want to get worried, just don't look at it. So and forget about it. So yeah, troponinitis is more or less meaning that yeah, it's
an irrelevant troponin levels, right?
Yeah, exactly. Yeah.
Okay. Can I ask another question, Sheila?
Of course.
Looks like it's a hot topic. So when we are a regional stroke center in London, and we receive patients from other hospitals who come with troponin I, to high sensitivity troponin I, and it's always invariably normal, but we do see increases in troponin T levels with normal CK. So if you had to pick up or choose one of the available troponin assays, which one would you choose for patients with stroke? I know it's a difficult question, but
yeah, I think yeah, it's an excellent question. So there's always been a discussion whether certain assay types like troponin I or troponin T are better with regard to diagnosis of acute coronary syndrome, and so I believe that every assay has its specific cutoffs and strengths and weaknesses, but I would not generally say don't use high sensitivity troponin I, or always use troponin T. So I think this has not been shown that one assay is clearly superior to the other.
Okay, thanks.
Perfect. We have several questions yet. I think we should answer these questions through Twitter. What do you think, Luciano, Gian, and Simona? They can put the questions on Twitter. Alina, we have to finish.
Yes, I'd say we can finish, and we're happy to post them on Twitter, and we can discuss them there, or I can send them to you, and you give written answers.
Maybe we can name the people who posted the question in Twitter, so that they can search their names, and then we will answer to them.
Yeah, perfect.
Yeah.
Okay, thank you, everybody. These wonderful presentations and questions and answers. So, Alina, thank you.
Yes, I will just, we've gone quite over time, so I'm just going to use this opportunity to announce our next webinar, which is on Thursday, 11th of March at 10 a.m. CET. So if you're located in Europe or Asia, you're welcome to join us, and we'll discuss the topic how to detect brainstem and cerebellar stroke. We're going to have Patrick Michel from Switzerland and Jong S. Kim from South Korea with us. And I'm sure it will be a great discussion. So that's all for it from me for tonight. Thanks all for participating, and see you next time. Bye.
Thank you.
Bye. Bye.